So hello everyone. Thank you so much for coming. Really excited to have this talk today. We are just going to give you guys a couple of minutes just to sort of shuffle into the room, as it were. I can see people are starting to log in, so that's really good. Thank you so much. We are at 7:01, so we'll start at 7:02. Please feel free to put any questions in. I'll keep the chat open. We've got a Q&A as well, so we'll have someone looking after the Q&A as well. Just please make sure that yeah, just ask whatever you want, and we'll try our best to try and answer those questions. We've got myself or Irfan who's here as well to be able to answer those questions, and obviously Dr. Zafrani, who's a special guest here today. So it looks like we've got a lot of people from all over the world. A very interesting subject, no doubt. We're talking about female health and the postpartum athlete, and that can be a really interesting topic. It can be a real challenge for people, from what we know. Let me just have a look at the time now. We're doing okay. Yeah, so feel free to put down where you are, say hello. It'd be really interesting to know where people are coming from. And I think what we'll do now is start get things going. So my name's Dr. Lasker. I'm a consultant radiologist. I'm really lucky to have Dr. Lamia Zafrani with us. She'll be joining us just a little bit later. And we've got Dr. Irfan Ahmed as well. He's an MSK practitioner as well, sports medic. So what we're going to do is go through this subject here, the pregnant and postpartum athlete. This is hopefully going to help some of you guys who may have patients along these lines, or someone who may be an athlete before or after having a pregnancy, are trying to get a little bit more athletic, get back into the gym, get back into fitness and that kind of thing. We have been working very hard in the background of the MSK Playbook team. We've been doing all sorts of stuff over the last few weeks. We've done ultrasound courses. We've been publishing more things on more articles on the Sports Medical Journal. You'll be able to find those articles on our website if you want to have a go look at it. We're going to have a question and answer session at the end of it, but if you are interested, you can actually go to our website, join the course, and you'll be able to get these graphics that we are making before everyone else. So before they get released on to the general public, you'll be able to access these nice little graphics where we talk about various things that are very common and very important for athletes and sports medics and anyone that's dealing with these kind of patients. So for example, this one is about spinal insufficiency fractures. There's a really nice graphic. If you're in clinic, it may be worth just having these up for yourself or your patients and go through some of the things that can result in sacral insufficiency fractures. So what are we aiming to do today? We are going to be going through what we're talking about, the postpartum and pregnant athlete. But before we do anything else, I wanted to sort of get everyone going, get into it, and go through some imaging, because imaging is the best part of anything, really, in my humble opinion, being a radiologist. And what we're going to do is go through I guess she was a 40-something-year-old patient who came in and she wanted to get fit again after a long period of long time off, and she's got left-sided hip pain. And you've got this patient and you're trying to examine them, and they seem fine. They've got good movement, they've got good strength, 5 out of 5. Walking is fine, the gait is fine, but they're really complaining of sort of a pelvic pain, and you don't really know what's going on. So your options are, you can watch and wait and think, okay, well, maybe you should rest it. Maybe you've sprained a muscle. It could be a muscle sprain. And let's say you say, okay, I'll see you in a month, 2 months, 3 months, and see how it's going. It doesn't get any better, pretty much the same. And now you've got to think about what to do next. So when you're out in the community, the next best thing can be just to do an ultrasound scan. I say just to do an ultrasound scan, but ultrasound scans are very good at looking for superficial structures. People often have this hierarchy of which scan is better than others, but there are some scans that are better at certain things than others. And ultrasound in the right hands can be very good. Which is why we run an ultrasound course, trying to teach people how to go from basics to be able to conduct doing ultrasound scans of various parts of the body, various bones, various tendons, and that kind of thing. That's a full 2-day course. But let's say you send this patient for the ultrasound, they've done the hip ultrasound, and they've said, you know what, there's a really big lesion located over the left hip. I'm a bit worried. And you're saying they've got this pelvic pain. I think we need to do some kind of investigation. So your next investigation, it's going to have to be an MRI scan. MRI scans are formidable, absolutely amazing when it comes to MSK. It's the bread and MSK. It is the absolute bread and butter of MSK radiology and MSK imaging. And without it, we wouldn't be able to diagnose quite a lot of things. So If you want to take part of this as well at the same time, you'll be able to go to the MSK Playbook website and you'll be able to log in and be able to get to an area called free stuff. And when you get to free stuff, you would access this particular slide. If you go to slide 8, you notice that it looks a bit blank, but as you kind of scroll through, you notice actually this is an entirely scrollable case, just like you would if you were in a clinic. If you were me going through the cases, you can scroll through this image and try and see what's going on. So at first you think to yourself, okay, well, it looks okay to me. It doesn't look like there's much going on. Just to explain where we are, because I know not everyone knows what we're looking at. First off, we're looking at a human body, but from top to bottom on this side over here. So this is from top to bottom. This is from in front, and this is from top to bottom as well. So this is called axial, this is called coronal, and this is called axial. But the point is you're looking from top to bottom. But you'll notice that it's the same person, it's the same patient, but this image looks different from this image, and this image looks almost the same as this image and this image. But these all look different from this one. One looks a bit darker. That's just one way to put it. And the reason it looks darker is because what they've done is artificially make the fat look very, very black. So that's fat. Everyone's got a bit of fat. It doesn't matter how often you go to the gym, everyone's got a bit of fat under their skin. But when you got this particular sequence, this is called a fat saturated image, where they've saturated the fat out of the image. So anything that should be bright, that is fat, will be now dark. So you can use that to infer what something is if you're not entirely sure. So if you've got like a fat lesion there and it suddenly becomes black, and then you think, okay, that's some sort of fat lesion. And you can see the bones, they've got lots of fat within them. And therefore, when you go to this particular sequence, the fat looks black. And then as you kind of scroll through, we had this left-sided lesion, right? So I want you guys to pay attention to this middle one over here. And as I'm going to scroll through that in just a second, we scroll through, scroll through, scroll through. So we're going through the human body. And at this point, we do have something quite abnormal. If we look at the non-offending hip, which is this one, this looks okay. You've got nice muscles going up this way. These are your gluteal muscles. But when you go to this side, you've got your gluteal muscle over there. But this muscle looks a bit weird. Can you see that? If you look at that area there and compare it to there, it looks like there's a bit of extra sitting over here. Something very, very strange that's sitting over here. It looks like it's within the muscle because the muscle should be nice and flat and thin. But this muscle looks like it expands outwards and goes along like so. So there's a lesion here, and that must be what they were talking about on that recent ultrasound. So you think to yourself, okay, well, we've got a lesion. What could it be? It could be a fluid lesion. It could be a fat lesion. It could be a muscle lesion. It could be any of those things really, because we're in that kind. Or it could be bone. It doesn't quite look like bone because you don't have that thick black cortex around it. But it could be fat because it kind of has the same signal as fat, but it doesn't have the same appearances as muscle. But at this point, okay, if we're thinking this fat, it could be fat, but therefore we're going to use this sequence over here. Because remember, everything that's fat on this sequence will now be dark. So we now need to pay attention to the left hip that's over here. So what we'll do is just scroll through again, come back to that image, and we found that lesion sitting right over here. Can you see that? And it has gone dark. It's very, very black. So if it's bright on here and dark on here, and all the fat is dark on here, this must be a fat lesion. So at this point, we think to ourselves, okay, well, it's a large lipoma, and lipomas aren't usually a problem, but maybe because it's sitting over the hip, it may be causing some impingement, it may be causing some irritation, plus it's quite large. This could be the problem, and this could be the cause of this patient's pain. But actually, it's a bit of a red herring. There is something else on the scan that's not entirely right. There's something else that could be causing pelvic pain that may be worth looking at a little bit closer. So when we were looking at this particular sequence, we said that the fat was bright, but something else is also bright on the sequence, and that is fluid. So fluid is bright. Fat is also bright. So therefore, this means it's something called a T2 sequence. Not important. The only point here is that you look at the things you know to try and figure out what things should look like. So you know the urinary bladder is full of fluid, it's full of urine, therefore it's bright. You know the fat is also bright. So anything in this particular sequence that's bright is definitely going to be fluid. And as you scroll through, you'll notice that there is some fluid in all sorts of areas over here, all located within the bowel. But this area over here, it doesn't look like bowel. It just looks like two little dots that pop out of nowhere. You've got one that looks very, very fluid, and one that looks like is somewhere in between fluid and somewhere in between that's not fluid. So it could be fat because remember, fluid is bright and so's fat. So what we need to do here is go across back to here and try and look at this particular image and see whether this lesion that we're worried about becomes darker on this particular MRI scan. Because if it's fat, it will go darker. This lesion's gone a bit darker, but that has not. That's actually got brighter. So that doesn't really conform. We've got something that's bright and something that's bright. And you think to yourself, okay, so what is it then? I mean, it could be fluid, I guess. But then when you go to this area, it kind of looks in between. It doesn't really behave like fluid. So you've got a bit of a conundrum. You got a lipoma. Is that the cause of the pain? Whatever this lesion, is that the cause of the pain? And that's why it's really important to have a kind of a general understanding of what can cause pelvic pain in anyone, let alone an athlete. Yes, lipomas can cause all sorts of issues, but this lesion here that we're looking at, because it's not quite fluid and it's not quite fat, it's something in between, is something else entirely, and it's otherwise known as an endometrioma. So this patient has got endometriosis. Now, endometriosis, as I'm sure you're aware, can cause all sorts of havoc, can cause all sorts of pain, and can be a bit of a red herring. So we did see a well-defined lobulated fat lesion, and we could have got walked away thinking this is a lipoma. But the likeliness would have been that, yes, you may have sent this patient for surgery, they may have got it taken out, maybe they won't have as much of a lump feeling and everything feels fine, but they're still going to end up having that pain because the primary cause had not been sorted out and it was actually sitting there and just sitting there hiding away. The good things about it, the lipoma, it didn't look like it was invading anything, didn't look like it was particularly aggressive. But this little lesion over here is that sort of red flag. The thing that people don't see, they may just be really concentrating on that left hip and not really looking at the left pelvis. Because sometimes people with pelvic pain don't, they present in all sorts of ways. It could be abdominal pain, it could be hip pain, it could be any sort of pain. But in this particular situation, this very abnormal lesion that is bright on the fat I mean, yeah, which is increased signal on the fat sequence, intermediate on the T2 sequences, is what we need to be thinking about. So this is how where it's very typical actually of seeing patients. So what you hopefully will realize is that when you have patients, they present a certain way, but they don't present in a textbook way. It's very, very common to kind of go down one particular path and then find yourself going down somewhere else. And that's why we've got these imaging cases where you kind of go through the case like we've done just now and work through these problems to try and enable you guys to identify at least what the radiologist is talking about. If they've seen something abnormal, therefore you can share with your patient, say, look, your reports come back, and this is the area that they're looking at. This is what they're talking about because of what I've just spoken about. So by doing this course that we do with the MSK Playbook, you improve your own confidence, and sometimes people are even able to pick up their own red flags whenever they're going through the scans before the results even come through. So if you are either interested in learning a little bit more about sports medicine and how to correlate the two things, MRI scan, some of the evidence that comes up with looking after patients, stuff like trochanteric bursitis and all the kind of conditions that patients have, then feel free to come to our Zoom course. This is the link, and we'd love to see you on there. And we also run an ultrasound course as well, which has been very, very popular so far. So without much further ado, I'm really, really excited to have my colleague, who's a UK trained consultant and OBGYN, graduate from Manchester and amazing powerlifter for 15 years. So I'll be quite interested to know what your maximum was a PR rep is. And then you're also an award-winning perinatal practitioner of the year, which is really remarkable and amazing achievement. And you're a real kind of leader in the field of sports medicine and for pregnancy and postpartum athletes. So I'm going to pass it on to Dr. Lamia Zafrani, who's going to be taking over for the rest of this talk. So like I said, if any questions stand up, please do feel free to ask the questions. And what I'll do is I guess I'll have to make you host. So let's do that, change host.
Right. I was going to say thank you for your case as well. It's really interesting because obviously I get the reports, the MRI reports, and we get exactly this kind of patient that finally we find it's an endometrioma when they come to gynae. It's really interesting actually having someone talk you through the MRI so that you can actually see how you guys have actually come to that conclusion as well. So thank you. That was really interesting.
Thank you.
Right. Can everybody see my screen? Now, I haven't found a way where I can actually do the presentation and see you all. So if there's any questions or anything, obviously just shout and let me know.
We'll keep an eye on the questions as we go, and I'll update you. Thank you so much, and we look forward to this.
Great. So my name is Lamia Zafrani. I'm an obstetrician and gynecologist. I'm going to be speaking to you about the pregnant and postpartum athlete. So why am I here and why am I speaking to you? So I am an obstetrician and gynecology consultant who specializes in elite athlete health. I work with recreational and elite athletes to help support them through maximizing their performance in pregnancy, postpartum, and essentially generally through any women's health concerns that they may have to ensure that they have a longer career. That's my private work, and my NHS work. I am a maternal medicine specialist. So essentially I work with women who have pre-existing medical conditions that are affecting their pregnancies. Ideally, we see them pre-conception to try and manage some of these conditions before they become pregnant. But essentially that is what my job sort of as an obstetrician in the NHS is, which does tie together everything quite nicely. I wear quite a few different hats, which they are quite relevant because, again, we're here talking about the pregnant athlete, which does bring up sort of equality, diversity, inclusion aspects of sports medicine. And actually, I work alongside sort of essentially as BAME engagement lead in my NHS work. So reducing the disparities in healthcare in maternal morbidity and mortality in the Black and ethnic minority populations, which you'll have seen the recent report that came out in the news. But essentially, I'm also a recent pregnant athlete myself. I've been a powerlifter for over 15 years. I'd say recreationally, definitely not elite. And my little one is 8 months old. And I did get to put everything that I now teach, I train, I work with in theory into practice with myself. And having the lived experience is definitely interesting. And we can talk more about that. Feel free to ask me any questions when we get to the Q&A part. But essentially, why am I here talking about the pregnant athlete? So we know, whilst we don't have any published data on clear percentages of what are the dropout rates in elite athletes due to pregnancy, we know from empirical evidence and qualitative research and surveys, they point to exactly this. We know that up to 45% of athletes believe that they need to retire to start a family. They still believe that they need to retire in order to start a family. If we look at surveys in elite football, only 2% of elite football players are mothers who have gone on to have a pregnancy and have continued back to sport. However, 24.6% of elite footballers go on to have a family after retirement. Having said this, we know that where there is a will, there is a way. And in other sports, such as ultramarathon running, which you could argue is a relatively newer sport in that sense, up to 60 to 70% of elite marathon runners actually go on to become mothers and continue postpartum. And actually, we find that they are breaking records, their personal bests. So they do come back fitter and stronger. So if I haven't already convinced you about why we need to be speaking about the pregnant athlete, I usually look at things in sort of splitting it into three. So I would say that there's a population and public health aspect, there is an athlete aspect, and then there's a club, team, governing body aspect of why we need to be considering this population. So we know that women make up just over 50% of the world population, and of that, 85% of the female population will become pregnant, unplanned, planned, etc. So it's not really a niche population. You're all going to come across a pregnant woman or pregnant athlete at some point in your careers. In terms of public health, we know that we have an obesity epidemic. So this isn't just related to athletes. Pregnancy can actually be a really great motivating time in a woman's life if it's a planned pregnancy. And if we are not able to give the right advice around physical activity in pregnancy to women who are otherwise might be quite motivated to make changes, then we're actually missing out on something big here. I can see your hand has gone up.
Yeah, Dr. Zafrani, you've had a really interesting question at times and really nice with this slide. So thanks to our participants. So the question is there a reason that the sports associations do not promote policies and practices to ensure athletes are not retiring in order to have families? There's a really nice BJSM paper that was published recently that says, less than half of the international federations have a policy for the postpartum or pregnant athletes. So I'd wonder, what's your thoughts on that? And we will share the link as well. So I'll hand over to you to answer the question.
I think a lot of it is, I think it's changing. So more governing bodies are realizing that some governing bodies have got a policy. So, essentially they're going to be left behind if they're not actually making progress in this area. I think a lot of it is mostly to do with the unknown. we still don't have enough female athletes becoming pregnant in their careers. More and more of them are, but essentially, as more and more of them continue to do so, we'll be able to gather the evidence base to say, well, actually, this is definitely possible. So yes, remind me what the question was again. Why are not?
Is there, yeah, is there a reason why sports associations do not promote policies? And I guess, a follow-on question, what do you think they should be doing? What do you think they should be doing to fill the gap?
I think, well, I think if we wait for, and I always say this, if we wait for lots of athletes to get pregnant to be able to then make policies, make guidelines, make recommendations, then we're going to be missing the boat and we might never get there. So the best way to be generating some research, and this is kind of what's happening with, especially with the Canadian research group that's put out a lot of really good research recently, is athletes are going to do what they're going to do. So actually, whilst we know that randomized control trials, meta-analyses are better and have more power, case-based and case studies are not necessarily irrelevant in this sphere because we have got limitations with how we're going to be able to get our data. So watching athletes who are going to get pregnant, return, etc., and see what they're doing and support them as best as we can, that will actually and is contributing to the research. But back to the governing bodies and why they're not promoting, I guess a bit of politics. I mean, there's still a belief, again, 45% of athletes believe that they need to retire to start a family to an extent from a governing body, from a sports club, etc. When there's so many question marks, would you really risk your athlete by encouraging them to get pregnant, etc.? There's never a guarantee that someone is going to return. Now, it might be because of personal reasons they decide that they don't want to return, etc. So retirement is very personal, but I guess from a governing body, sports organization perspective, it's still very gray, and they possibly politically don't want to be seen to be encouraging pregnancy when they don't know that they're definitely going to get a return on their investment. But we will talk about this as well. Did that answer the question to an extent?
Yeah, that's fantastic. Yeah, we will have more time for questions at the end. Thank you so much for that.
Yeah. So yes, that brings me back to this slide, which is that athlete care has advanced. We know that female athletes are having longer careers. We know that they're choosing retirement later and later. And they are also wanting to consider fertility and wanting to consider having a family. And whether we support them, or whether there's guidelines, whether there's policies or not, athletes are combining motherhood and athleticism, and they are also choosing to return postpartum. But one thing that I'm very, very passionate about is that motherhood does not need to be career ending. We know from physiologically, the changes, which we're going to talk to, the physiological changes in pregnancy, they actually promote, even sedentary women, potentially the load of pregnancy, if you did nothing else other than just be pregnant, at the end of it, a lot of the physiological factors such as heart rate variability, resting heart rate, they do actually improve just by being pregnant. So for athletes, when they're already working at a higher level than the average sedentary person, it definitely does not need to be career ending. And if anything, we talk about mum strength or mother's strength. Some of these mums literally they do have superhuman powers, it feels like. So in athleticism and in terms of athletes, a lot of female athletes who do return when they've done it correctly do find that actually they're exceeding, and we see this in ultra marathon runners specifically. And my last point on this slide is we have a legacy to protect. So if we are serious about women's sport and we are serious about women's sport flourishing, we know that there is a widening participation gap, gender participation gap in sports, with girls being affected negatively, and that starts at puberty. So from menarche, and that just gets wider and wider. So if we are genuinely, from a public health perspective, and a women's sport future and legacy perspective, we care about encouraging girls and women to stay in sport, then we really should be serious about supporting women and supporting girls through all aspects of the female life cycle, straight from menarche, with menstrual disorders, through to pregnancy, postpartum, and even perimenopause and even menopause. Ooh. So why consider the pregnant athlete from an athlete perspective? So a lot of athletes, they wish to have a family and they wish that, they have fertility wishes. Now, surprisingly, or not so surprisingly, in my private practice, a lot of the work that I do with athletes is actually preconception work. A lot of them will come and ask me, can I just have a gynae MOT, a preconception MOT, essentially tell me what's my status from a fertility perspective, because they're trying to make decisions like, do I wait for retirement or do I consider having a family now and coming back? And, these are all very valid questions. And essentially, I'm all for informed decision making. If someone wishes to wait till retirement to have a family, that's completely fine, as long as they feel that they are informed about all the things that they need to be informed about, all the implications of that, rather than what I find in practice, which is a lot of athletes just have never had these conversations, have never had the opportunity to have these conversations. They almost feel they can't bring it up to their performance teams or anyone around their performance side because it would question their commitment to the sport. When actually we need to be breaking that down. That is not the case. And if we see that it's not the end of your career, then from performance team sides as well, we will feel much, much happier having these conversations as well. They have a wish for continuing their sporting career for longer, and they don't necessarily want to trade fertility for their career. And a lot of athletes, I found this initially quite surprising that it wasn't obvious, but I guess because I'm a gynecologist, it's very obvious to me that, we can talk about women's empowerment and everything and every other aspect of life, but with biology, we have a biological clock. And, I was very surprised that not everybody appreciates that, if you wait after a certain age, that it's that you do have an increased risk of fertility struggles. And by waiting for retirement, a lot of these athletes didn't realize that they may have fertility struggles. Not everyone will, but the chances are higher. And again, if you know this and then you make an informed decision about your career and your wishes outside of your career with that information, then that's completely fine. But if that information is not given and then they're making decisions, then I find that a lot of athletes I speak to when they're having fertility struggles, that they felt that they never had that information. And a lot of athletes wish to return postpartum, so they don't necessarily want to stop competing after they become mothers. Again, that may be for legacy reasons. They want to continue their legacy. It may be financial reasons, contracts, sponsorships. And an interesting one is identity, so athlete identity. There's some interesting, really good work done by Kelly Massey, based at Liverpool University. She's an ex-Olympic athlete. Her research paper that was released recently, I think either this year or last year, but essentially it was looking at shifting athlete identity through pregnancy and postpartum, and it's really interesting. It brings up a whole additional aspect, which is the mental health aspect, which I'm going to touch on so as we go throughout the talk as well, which is really, really important. So a lot of athletes would not want, when a lot of their identity is built around their sport, to suddenly have to give that up. And again, now looking at the third side of this triangle is the club, the team, or the sport itself. Clubs and teams have made investments into their athletes. Now, because we don't have any data, sort of any percentages on the actual dropout rates. But if we were to look at projected earnings and projected investment, if an athlete was to retire, say, 3 to 5 years earlier than they would have, then you're looking at, on average, anywhere between £2 and £5 million of lost investment, essentially, from a club's perspective. So it's important for clubs to be prioritizing looking after pregnant athletes, because they have made lots of investment, and you would want to be making a return on your investment if you're looking at it purely from a business perspective and not even from a player perspective. Again, the other aspect that teams and clubs and sport in general should be mindful of is reputation. We know of cases in the US and closer to home as well of athletes who have, their teams or their sponsors have run into trouble by not offering maternity protections or cutting contracts, etc. And the reputational damage that comes from that, if, again, from a business perspective, you would want to be protecting that. even if it's, you're not looking at it as the right thing to do. Performance timelines and competition cycles and seasons. That's another important thing for clubs and teams to be looking at. This is why, again, I'm a big believer of preconception counseling and preconception work, because if an athlete in an ideal world, let's say you're an Olympic athlete, you've got 4 years between Olympics, if you can ideally get pregnant sort of as early after an Olympic and before the next one that you want to compete in, obviously it gives you longer to recover, rehab, rebuild, and come back, and increases your chances of being able to return strongly. But again, when I work with athletes and teams and etc., I always say there's best, there's better, and there's good enough. And sometimes, a lot of the times, we're dictated by performance timelines. So is there a season deadline? Is there a competition cycle? We will work towards whatever constrictions we've been given. But if we're looking in an ideal world, and these clubs and teams who are writing the maternity policies and guidelines, if they can be aware of what the physiology of pregnancy is and postpartum, then we ideally would have better timelines to work with. But essentially, performance timelines are a very important factor, and sometimes they're out of our hands as the athletes or the teams that's supporting the athletes. And another important one is team dynamics. Sorry, I've just seen a hand go up.
We've had another really interesting question. Thanks a lot. It's generating a lot of discussion. So you mentioned about teams. So we've got a lot of people in the audience who are working with sports teams. Maybe they're a sports physiotherapist or a sports medicine physician or a primary care physician. And the question is, as a sports gynecologist, we do a lot of screening in sport. Are there any particular clinical history, family history questions you'd like them to ask in screening? Are there any blood tests or imaging, things that would start a discussion around fertility planning? Anything you would recommend?
So interestingly, the case we had at the beginning about endometrioma, we know, and again, the NICE guidance says that usually we would advise anybody under the age of 40 to sort of under the age of 35 more. If you were to try to conceive for 18 months, essentially 85% of women trying to conceive would achieve conception within 18 months. The rest, yes, up to 95 would achieve conception within 2 years. Now, the only time that timeline has to be shortened is if you have certain things such as primary ovarian failure as a family history, or you are over the age of 40, or you have a personal history of a gynecological condition that would affect fertility, such as polycystic ovarian syndrome or endometriosis. So if you have either PCOS or endometriosis, then actually we would advise that you try to conceive for 6 months and then start the process of seeing a gynecologist to start the subfertility workup. Not that that we would need to do anything in terms of IVF or anything else. It would just start the process because you already have something that has a risk of affecting fertility. Now, not everybody with endometriosis will have fertility issues, but 40% of women that have fertility issues happen to have endometriosis. So it's quite subtle, but yes, going back to the question in terms of screening, you'd be looking at their full gynecological history and a bit of family history as well. But essentially things like age, general health, RED-S is a specific one. If they've had a history of RED-S, we know that, again, new emerging evidence does suggest that we know that it can have an implication not just for fertility, but for pregnancy and outcomes of pregnancy for both mum and the baby. So yes, in terms of screening, gynecological history, RED-S history, and just generally optimizing their health in general for conception. Does that answer the question?
Great, thank you for that insight, and hopefully that gives lots of tips for people to take away, particularly if you're doing pre-season or signing medicals and starting those early conversations. So thanks a lot.
Yeah. And the final point on this slide was team dynamics. So again, yes, in certain sports, if collision combat sports, if you are pregnant, you're almost signed off. But then when I speak to the athletes, the ones that felt not very supported would usually say that they felt like they really weren't part of the team anymore. They almost felt sidelined, and actually it impacted their mental health in terms of their wish to return and want to return and ability to return. Whereas those athletes who had a really great experience through their pregnancy and postpartum return, like I remember speaking to one netball athlete, she specifically said that one of the things that she loved was the fact that her coach kept her involved. So even at the point where she wasn't physically in the physical side of the training, she mentioned something which was really interesting. She was just involved with sort of giving out the water bottles and speaking to everyone and towels, and it wasn't necessarily a physical sort of her training, but she still felt part of the team, and she said that for her was really important. So again, team dynamics is a really important, often overlooked part of the pregnant athlete. And now we'll move on to pregnancy physiology. So a lot of physiological changes happen quite early on in pregnancy, cardiovascular, respiratory, musculoskeletal, and metabolic. And a lot of these would start happening potentially before the patient, the athlete even knows that they're pregnant. And this is what would explain a lot of the symptoms that your athletes would be experiencing in the first trimester, which are very difficult for them to sort of get their heads around, because in the first trimester, you're not visibly looking pregnant. A lot of the time, you're not disclosing that you're pregnant. You may not even know you're pregnant, but something just feels a bit off. And you would mostly, with athletes, they would start noticing that something's not quite right in one of their training sessions. They then test a few weeks later, they realize they're pregnant. But cardiovascular changes, you get an increased plasma volume. So the amount of fluid that makes up your blood increases. Some of the components don't necessarily increase. So essentially the hemoglobin wouldn't increase, but the plasma volume would. So you would get a relative anemia. So it's not necessarily a pathological anemia. So it's not one that needs anything doing. It's essentially a physiological anemia. But that's why we have different parameters in pregnancy when we look at certain things before we would diagnose it as anemia, for example. The other thing that happens, the other main aspect cardiovascularly, is that you get a decreased vascular resistance. So the pressure at which the blood is going through the vasculature decreases. That's partly to help with how the placenta is forming and implanting, etc. But essentially what that means in practice is that you get a reduction in your blood pressure. And that is why you may notice that your athletes are complaining of feeling dizzy and struggling. And that is usually due to low blood pressure. And we know that blood pressure generally goes down in pregnancy. So again, it's quite normal to see women with a blood pressure of 80/50, 90/50, and they're still fine and they're walking around, because actually that's just the physiological change in pregnancy. Respiratory changes, they would get an increased tidal volume. So whilst tidal volume increases, a lot of other parts of the respiratory function doesn't actually change. So essentially what they would get is some women are just more sensitive to these physiological changes, and they may feel essentially shortness of breath or a perceived hyperventilation. From a musculoskeletal aspect, the estrogen and progesterone and the balance between the two, essentially you would get increased ligament laxity, which increases the risk of something called SPD, so symphysis pubis dysfunction, or otherwise known as pelvic girdle pain. But essentially, what that means is that you have your pelvis, which is essentially normally has fixed joints in certain areas and ligaments that are of a certain laxity. But and a lot of athletes we find have hypermobility. So if you already have hypermobility, you're then at increased risk of developing further laxity due to the hormonal changes and then getting something called SPD. So what is SPD? Essentially, you have your pelvis, and outside of pregnancy, the joint at the front in the symphysis pubis is a fixed joint. In pregnancy, it becomes a bit more malleable and a bit more lax, just to allow some space in the pelvis for vaginal delivery to happen. But essentially, in some women with hypermobility, for example, or otherwise, you can get movement in directions of the pelvis that shouldn't normally happen. And what that then happens is it creates pressure, pain, symptoms by trapping and nerves, essentially. It's a really painful condition, and it can start mostly if it does happen, affected individuals, usually from the second trimester onwards. And some of my worst case patients have ended up in wheelchair crutches by the third trimester. So it is quite serious. And then in terms of changing biomechanics, sorry, your center of gravity as the uterus grows will change. So that can then impact a lot of what we're doing in terms of movement, dynamic movements, etc. In terms of the metabolic changes, you get an increased basal metabolic rate, and you also get, all pregnant women will have an element of insulin resistance. It's partly to do with the hormones that the placenta produces. So all women will have an element of insulin resistance, but the women that then get diagnosed as gestational diabetes are the ones that have sort of gone over a certain threshold that we have. And it, yes, being fit, healthy, having a high muscle, having a high ratio of muscle mass to body fat does help protect you from gestational diabetes, but being fit doesn't necessarily protect you from getting some of these complications. And actually having polycystic ovarian syndrome predisposes you to getting gestational diabetes. And I find that quite a few of my athletes have got polycystic ovarian syndrome because actually the chicken and egg scenario, but actually the increased testosterone that you might get in polycystic ovarian syndrome actually makes you slightly better at performance. So I find a lot of the athletes have PCOS. So it doesn't mean that just because you are fit and healthy that you are not at risk of gestational diabetes. Yes, I see a hand.
Yeah, so thanks for that. That's really nice. Thanks for reflecting on the metabolic health. We had a question come in. So you've had an athlete who's delivered and has returned back to the team. Are there any groups of patients, either ethnic or due to an obstetric history, where you consider doing maybe routine checking of their blood sugars or diabetes status or oral glucose tolerance tests? Tell us a bit about that and what types of groups of patients you might be thinking of screening, perhaps maybe in future seasons.
So anybody who has had gestational diabetes, we know that their risk of getting type 2 diabetes in their lifetime is increased. Just in the same way that we know that if somebody develops preeclampsia in pregnancy, their risk of getting cardiovascular disease in their life is increased as well. So these are essentially, we use these as screening tools, really. So anybody who has gestational diabetes in their pregnancy, we would normally advise in the UK that they have a annual HbA1c, essentially as a screening to check that they haven't developed type 2 diabetes. In terms of other ethnic groups, well, I mean, the way we work in the UK, there isn't, the guidance doesn't officially state that if they haven't. So, for example, if you are of a ethnic minority background that has an increased risk of gestational diabetes, like Black and Asian patients, they don't, and they didn't develop gestational diabetes, we wouldn't necessarily go on to continue screening them. Only if they did develop gestational diabetes would we recommend that they have an annual HbA1c to keep an eye on things.
Great. Thanks for sharing that insight.
Yeah. And the final one is thermoregulation. So there's reduced efficiency of thermoregulation. So this is where you will find that a lot of women will complain that they're feeling hot, especially in summer, etc., because they're not able to essentially dissipate the heat as efficiently and as effectively as outside of pregnancy. So now we'll look at the considerations and challenges, and I've split it into trimester by trimester. So in the first trimester, the major challenges are, again, we touched on these a bit earlier, was, does the athlete even know that they're pregnant yet? Have they disclosed their pregnancy? And I think there's a lot to say about disclosing pregnancy status. A lot of the, women choosing not to make the sort of announcements around pregnancy until 12 weeks is rooted in your risk of miscarriage is up to 25%, 24 to 25% of every conception. So, there's 1 in 4 chance that I might have a miscarriage. But actually, I really feel like we need to be talking about things like miscarriage and breaking down the taboos, because if you are a woman, an athlete, etc., and a big part of what you're doing from a physiological perspective, etc., is changed so much with pregnancy. Would you not want the team, the people looking after you, sort of physically as well as from an emotional perspective, would you not want these people to be around you, even if you had a miscarriage? Surely, why should women have to go through these things alone? And I think that's a topic for another day, but definitely one that I am very passionate about. But yes, again, a lot of sport may expect early disclosure, such as combat and collision sports, but otherwise, does the athlete even know? Does the performance team even know in the first trimester? One of the main issues in the first trimester tends to be nausea and vomiting and reduced energy. And nausea and vomiting can be anything from just constant nausea to actual nausea and vomiting, to everything that can lead up to something called hyperemesis gravidarum, where it's essentially such severe vomiting and nausea and vomiting that the patient would lose up from 5 to 10% of their body weight. That is essentially a medical emergency. This is what we see in hospital when women are admitted and hospitalized for IV hydration and antiemetic therapy. So it can be anything from annoying nausea to something quite serious. Again, and the strategies are mostly supportive. We haven't, even with all the research evidence that we're all the research that we're doing into nausea and vomiting in pregnancy, we still don't know what the actual physiological reason and how and why nausea and vomiting in pregnancy happens. We have had some recent research in the last 18 months that has suggested a particular hormone that some women are more sensitive to, and there's some talk about trying to incorporate some medical therapies in exposing these women beforehand so that when they're pregnant, they don't have such a severe response, but it's a space to watch. But again, from an athlete perspective, if these women are up all night, they're vomiting, their hydration status isn't great, their nutritional status isn't great, their energy is going to be reduced, and then they are trying to make their training sessions, we just need to be a bit mindful. And it's difficult because in the first trimester, you don't look pregnant. So many changes are happening and your body has not yet adapted to these physiological changes, which are relatively abrupt when they happen. But yet, physically you don't look pregnant. So unless you tell people what's going on, they're not otherwise going to know what's happening. And my last point on challenges is actually IVF and fertility issues. So there's a huge, again, mental health consideration, which I think performance teams should be aware of, is we know from research evidence that exercise, sport, etc., nothing that you do physically can cause a miscarriage. And we know this, and this is sort of in published data. But when it comes to having miscarriages, especially if they're recurrent, even someone like me who is a gynecologist, and I know this from a logical perspective, even when I had my recurrent miscarriages, there was one point at which even I thought, should I be training on this particular week when, I had some bleeding, etc. So it's an important one for teams to be aware of, especially if you have athletes who have undergone IVF, etc. They've invested a lot of sort of emotion, finances, etc., into their fertility. And actually, even though the logic and the evidence says one thing, they might still have that voice that, despite all logic, might make them question about how and what kind of training they should be doing in the first trimester. And we should be mindful of that. So in terms of considerations, when you have an athlete that is struggling in the first trimester with nausea, vomiting, reduced energy, or other mental health considerations, it's worth looking at reducing the intensity of the training, reducing the load if that's required, especially paying attention to nutrition. So strategies to manage their nausea and vomiting. We know from some evidence base that having a higher protein and higher fat diet is actually beneficial in protecting against nausea and vomiting in pregnancy. But we also know that by the time that the nausea and vomiting is actually underway, it's very difficult for people to then want to eat certain things. So it's usually better, again, preconception, if you've got a high protein diet already, it may help in reducing the amount or experience of nausea and vomiting. But otherwise, things like hydration and using electrolytes to help with hydration alongside medical treatments such as antiemetics, anti-sickness tablets. And we sort of touched on this, but even a temporary pause in the training altogether, because essentially the first trimester, as every trimester, it is temporary, as is pregnancy. Everything is temporary. So if you need to take a temporary pause because you're physiologically not in a place to be able to perform, then that is completely fine. And nothing bad will happen to your overall sort of fitness levels and training. Yes. Another question?
Great, fantastic. Generating a lot of questions this slide. So we've got another question saying, does the anti-doping approach change for pregnant athletes? And secondly, do you see pregnant athletes in their first trimester becoming more self-aware of their food intake and supplements, particularly if they're working like in a group team environment?
Okay, so the first question was on what was the exact
Anti-doping. Does the anti-doping approach change for pregnant athletes?
It depends what you mean by that exactly. So I know, for example, with the supplementation that we recommend, folic acid, etc., all of that pregnant care, none of these are actually none of these are actually tested. So it is a difficult one. And actually, I am working with / in discussion with somebody who's actually working in that area of trying to get fertility awareness in the fertility sector, as well as multivitamins, prenatal vitamins, etc., to be batch tested so that they do conform to anti-doping strategies. But other than that, I'm not sure I understood what else. I don't know if they mean
And
something else.
do you see pregnant athletes in their first trimester becoming more self-aware of their intake of food and supplements? Is the second part of the question.
I think it is very variable. I think athletes definitely are less aware in general than I would have hoped, and I always find that surprising. But actually, I find it surprising probably because nobody's actually ever sat down and spoken to them about sort of nutritional intake, etc. But yes, again, if it's a planned pregnancy, and I find that they usually are a bit more aware, but then they still have the challenges, such as they've got the nausea, they've got the vomiting, they don't know how to actually to sort of combat those. But generally, when I speak to a lot of the athletes, a lot of them have actually said to me that they've ended up going into Red S sort of mainly postnatally, because they've not factored, or nobody's advised them to factor in the extra calories that they need from breastfeeding, for example, for breastfeeding. So they've actually ended up falling under. So whilst, yes, I think the will is there for them to get more information, but I think there's still a void in the information and who's around to give that information in terms of dietitians and nutritionists, etc., and having access to these people.
Good. I've got two more questions, but I don't want to steal your thunder because I feel like you are going to talk a little bit more about a few more cases and perhaps the postpartum athletes. I'll hold those two questions, and if we don't get them answered, I'll ask them to you.
Sure. So the second trimester, this is usually when you start feeling better. So the nausea and vomiting subsides. Is that hand gone back up? No?
Hands down.
Okay. So yeah, in this trimester, the nausea and vomiting usually starts to subside in most cases, or if it doesn't subside, it gets a lot better and manageable. The adaptations, the physiological adaptations have sort of happened. Your body is starting to sort of cope with them better. So you essentially, as an athlete, start to feel better. So the challenges in this trimester is actually doing too much too soon, because you've had a rough first trimester, and then suddenly you get some relief and you think, oh, this is great. I'm just going to crack on and go back to doing what I was doing. And actually, this is where the most important thing for the performance team and the people supporting the athlete around them is to actually start screening processes. I would say ideally for certain things like the pelvic floor, you would have screened athletes sort of even before pregnancy. But let's, for argument's sake, say that that doesn't happen, because I know it doesn't happen. In an ideal world, that would, but you get to the second trimester, this is the perfect time to now be screening for things like pelvic floor function. Do they have any symptoms? Because essentially what we're looking at is load and dynamics. Do they have any symptoms even prior to pregnancy in terms of urinary incontinence, pelvic floor pressure, etc.? And what we find is that actually a lot of athletes never been pregnant before are struggling with urinary incontinence related to their performance and related to what sport they're doing, and they just put up with it because it's common. I always say that it's common, but it's not normal, and there is so much that we can do about it. And the other assumption that is made generally about urinary incontinence or urinary symptoms or pelvic floor symptoms is that if you have a symptom, it's because your pelvic floor is weak, when actually it couldn't be further from the truth. It may be weak, but what we find with athletes or women who are active is that actually one of the things that they have is a very strong pelvic floor. But essentially, they're still having symptoms because of all of the other dynamics that play into the pressure distribution in the intra-abdominal wall and downwards into the pelvic floor. And those are the things that we need to sort of modify in order to help with the symptoms. Essentially, if you have a very tight pelvic floor, your pelvic floor works in a number of ways in order to absorb pressure. So if you are putting certain pressures and loads onto the pelvic floor, it has to be able to absorb them so that you don't leak. Now, if it's already maximally contracted, for example, and you add additional force, it's got nowhere further that it can go, and therefore you leak. So actually, in those athletes that have a very tight pelvic floor, what we need to do is we actually need to down train their pelvic floor so that it learns to relax and coordinate so that they don't get the same pelvic floor symptoms. So again, looking at the second trimester in terms of the pelvic floor, there are certain movement patterns and things that you would want to reduce/remove if possible. And I always have these conversations with an athlete first approach, which is, for example, I will get asked a lot, can I continue running? And I would say, you can, but what is it that you want to achieve by continuing to run? Because running, if you don't have any symptoms, is great, but actually, even if you don't have any symptoms, what is the mechanics of what running is? So you are putting a pressure on and load on the pelvic floor each time you strike the floor. And over time, it's just accumulation of load on the pelvic floor. And you might be fine, but do we want, just because we can do something, should we be doing it? And that is an important nuance throughout everything that we do in sort of training in pregnancy. Can I versus should I? So again, pelvic floor physiotherapist is one of the #1 people that you should have in your team if you're looking after a pregnant athlete, pregnant and postpartum. If we move on to the abdominals, again, same thing with the abdominal and the core, essentially. We want to be looking at the load and the dynamics that system is, the sort of pressure and dynamics it's under. And essentially, every single pregnant woman is going to have divarification of the rectus muscles, so diastasis recti, essentially. It is not pathological in and of itself. You'll see fitness influencers, etc., online claiming that you can do this and do this to avoid getting a DR. You cannot avoid getting a diastasis in pregnancy. 100% of women will get it. It is a natural physiological adaptation to being pregnant. The rectus muscles will move apart to accommodate the growing uterus. And essentially, what you want to be doing or don't want to be doing in sort of the second trimester onwards is doing anything that further loads your abdominals in a way that is not necessary. So, if you're wearing, I'll talk about powerlifting because that's something I'm familiar with. Again, if you're wearing a belt, a lifting belt, while you're lifting, the belt needs to go because you're increasing intra-abdominal pressure, plus it will become uncomfortable as you get bigger as well. But anything that bracing techniques, if you're doing certain bracing and breath holding techniques as part of your lifts, again, you would have to change those, retrain yourself to sort of breathe through them rather than holding and sort of essentially eliminating Valsalva as much as you can. And whilst I do talk a lot about sort of lifting and powerlifting and strength, but resistance training is such an important part of all athletes' pregnancy journeys, especially the ones I've spoken to who've gone through and had to do it themselves without the support. They've eventually sort of moved towards resistance training when they weren't able to do certain things that were sport specific. But essentially, that's the outlook and the way of looking at things that we need to have as a performance team looking after an athlete. What is it that they need to do to be successful in their sport? What are the changes, physiological, biomechanical, etc., of pregnancy that means that that we need to make some changes? And can we achieve the same can we essentially get the same outcome, get them to be training the same movement patterns, etc., or doing something in a way that would still mean that it's beneficial to them for their postpartum return, but in a different way that doesn't necessarily load the pelvic floor, the abdominals, or cause dynamic movements that would increase their injury risk. And usually you would find that having a really good S&C coach on your team that has experience working with pregnant women or pregnant athletes is really, really useful, because actually a lot of those questions can be answered by resistance training. And we now know that the same Dr. Davenport's research group in Canada just this week or last week released a preliminary study on the benefits of resistance training in pregnancy. So the last thing is, again, talking about PGP and SPD. So depending on the symptoms, so if somebody's going to get SPD or PGP, it usually starts in the second trimester. Some people that are unfortunate, like myself, it started in the first trimester, but essentially mostly starts in the second trimester. So when you're looking at this unstable, extra hypermobile, lax pelvis, depending on the symptoms, again, you can't say that every single case of SPD is going to be the same. And the symptoms will fluctuate. So it's not linear in that it starts off and it just gets worse and worse. And actually, we find that with resistance training, that sort of strengthens the glutes, sorry, not gluten, glutes, and the stabilizers around the pelvis, you can actually find that that is helpful for PGP symptoms. But also removing single leg work. So again, if you find that the athlete is doing certain single leg movements, either for their sport or in their training, it might aggravate their SPD symptoms. So removing those, but essentially it's the one-on-one close work with each athlete, because each athlete's SPD symptoms will be different, and week by week, depending on the fluctuation of certain hormones, their symptoms may be different. So it's really important to essentially work closely week by week, make changes, sort of modify as you need them. And then we get to the third trimester. This is when you're very much obviously pregnant, the biomechanical changes, the center of gravity changes, but essentially all of these things together then increase the rates and experiences of pain, pressure, tightening symptoms. And again, because the uterus is expanded upwards as well as outwards, you get shortness of breath from compression of essentially the diaphragm. You get increased tiredness, and counterintuitively, you get insomnia, even from all of those symptoms, or even without those symptoms, just in and of itself. Some of the hormonal changes increase your rate of insomnia as well. So again, in this trimester, you're looking at reducing loads even further if possible, looking at modifying tension, so reducing and removing bracing and Valsalva if you haven't already. Again, using things like breath and breathing techniques, essentially rather than increasing intra-abdominal pressure outwards, but either breathing sideways into your lats or something called 360 breathing, and actually breathing through the movements rather than sort of breath holding, which is actually quite difficult. As someone who was used to bracing for heavy lifts, etc., in powerlifting, to then retrain myself to actually be breathing through rather than breath holding took a long time to kind of get your head around, but it's a very, and you can use the same technique. Pelvic floor physiotherapists use the same technique with patients who have urinary incontinence to actually retrain them to breathe differently through whichever movement pattern it is that's causing their leaking, for example. I see you had, a question?
Yes, and now we've got to the third trimester. I'm going to bring in one of the questions that we've had. So we've had a question saying, how far into the pregnancy do you advise athletes train? And do many make it to the third trimester? Is that often not practical? Are there any sports that lend themselves more to longer training? And I appreciate it might be sport specific, but it would be good to hear your thoughts on that.
Yeah. So what was the first part of the question?
How far into pregnancy do you advise athletes training?
They can train right till they deliver. It's really, really variable. So it depends on each pregnancy. So it depends on each pregnant athlete's symptoms. It depends on the sport. But if we're taking sport out and we're looking at biomechanical changes, physiological changes, if we're looking at them essentially wanting to continue training, then and they've adopted sort of resistance training and strength training measures instead, so that they continue to benefit from the hormonal changes of pregnancy and their fitness levels, then there is nothing to say that you can't actually keep training till the day before you deliver. I mean, in my case, that I actually did that. I was squatting 90 kilos, which isn't that heavy for me, but I was squatting 90 kilos the day before my waters broke. And to those in sort of CrossFit athletes, that's quite common as well. They're usually doing that kind of thing. In other sports as well, depending on the symptoms experienced, as well as what else is happening in the pregnancy. But there is no reason that you need to stop earlier unless you're experiencing certain symptoms, or we're going to get to certain contraindications, obstetric contraindications. What was the second and third part of the question?
Yeah, appreciate it could be sport specific. Are there any sports that you could do a bit longer and some that you might stop a bit earlier?
It just does vary, and I think we're going to get to talking more about sort of collision and combat sports, but generally the advice for collision and combat sports is that you stop after the first trimester. But actually, again, what I'm trying to sort of get the point across is that irrespective of which sport it is, if we strip back to the movement patterns that the athlete needs to be successful in their sport, you may not actually be doing the actual, let's give an example. So BJJ, MMA, you may not actually be on the mat, but actually you could look back and say, well, I need to be strong. I need to have a good core. I need to, so you could actually work on all these elements that make you good at the sport that you need to be good at, but actually do it in a different way. So through resistance training, through certain cardiovascular training, etc. So it might not be directly that you're doing the thing, whatever the sport is, but you can always break down what movement patterns it is that you need to be doing well in your sport and do them differently.
Great, thanks for that answer.
And yes, and I think the last part of the considerations in the third trimester was reducing certain dynamic movements. So like in football, for example, the abrupt stops, the changing in directions. And again, a lot of that is your center of gravity, and also ligaments, hypermobility, laxity, and similar to like we see that female athletes are at slightly increased risk of injuries at certain times in their cycle. It's similar. You don't want to be increasing their risk of getting specific injuries in pregnancy. So we talked about, or I mentioned obstetric complications, and I actually put a recent post not long ago on LinkedIn about the very few obstetric complete contraindications to training in pregnancy. And there are very few times that I would actually say outright no to an athlete. Like they'll say, I want to train, and we'll say, really, you can't in this particular case. Everything else is very gray. In obstetrics, everything is very gray. But in terms of there being sort of a black and white and sort of complete contraindication, something called placenta previa, which is essentially when the placenta can implant anywhere in the uterus. If it implants itself either on top of the cervix, which is the where the baby needs to exit from, or very close to, we could then characterize the placenta previa as either minor, moderate, major. Generally, the consensus what happens in practice is, from an obstetric perspective, we advise anyone who has a placenta previa or a low-lying placenta against sexual intercourse and strenuous exercise. Now, what we know from practice is that women don't listen to that advice and they will do what they do. And from watching that, what we have realized is that empirically, actually, it can be managed. It needs to be managed very carefully, and it needs to be managed alongside a performance-informed obstetrician and a performance team together. Essentially, if you have anything other than a major placenta previa and or bleeding, so asymptomatic, and you don't have a major placenta previa, you can potentially continue training in certain capacities, but it needs to be very, very individualized, and it has to be monitored very, very carefully. Essentially, and the reason for that is because a significant proportion of low-lying placentas will move out of the way as the uterus expands through the trimesters. It will move out of the way and you won't have a placenta previa anymore. So essentially, in those cases, and if there's no bleeding, then they can continue training, but it needs to be managed. Major placenta previa is when the placenta is completely covering the neck of the womb. In those cases, and or with bleeding, we would advise against training, essentially. An accretor is a different kind of placenta, evasive placental disorder, in which the placenta has actually invaded through the uterus and out the other side onto surrounding organs, such as the bladder, etc. In those cases, if you were to hemorrhage, it can be fatal. So we would, in those cases, actually, you'd be managed under a tertiary center for your delivery and for your care, and we would definitely advise against training in pregnancy in that case. In terms of preterm labor, that's another one that's usually another obstetric complication that we look at related to physical exercise. We actually know that there's no evidence that physical exercise causes preterm labor or increases your risk of preterm labor. But if you have threatened preterm labor, so you're having tightenings in the pregnancy, etc., at that point, until you either are delivering or it's a false alarm and you've settled, we wouldn't recommend training at that point. So, but even then, if you've got a previous history of preterm birth, depending on what the cause was and what the events are, you can be carefully managed alongside, again, a performance-informed obstetrician in managing and continuing to train in a subsequent pregnancy. Having said that, the only time I would advise against would be if we knew that you had a previous preterm birth and the cause of that was cervical incompetence, so your cervix not working properly. And we've gone so far as actually putting a stitch in the cervix to hold everything together. I actually had a case like this, and we ended up having an MDT because we haven't got the evidence to say one way or the other. And the MDT, we kind of decided that on the balance of risks, it wasn't worth, because we have a cause of the preterm birth, and we've got an intervention in place to prevent that. So actually, in that case, it doesn't make sense, and that would be a no. In terms of preeclampsia, there's a lot of advice and a lot of talk around high blood pressure and preeclampsia and whether it's safe to train in those cases. But actually, even in cases up until the point at which the blood pressure is not controlled, at that point, obviously, it makes no sense to then be training and increasing and elevating your blood pressure further. But up until we see a lot of preeclampsia because we screen for it really early and we screen for it well. So we pick up cases of preeclampsia much, much earlier than we used to be able to. So again, preeclampsia in and of itself doesn't mean that you cannot train. But if your blood pressure is labile, it's not managed, at that point, it's not, it wouldn't be recommended to be elevating it further. But at the point at which it is better managed, then at that point, it's not a contraindication to train. But other than these, most everything else in obstetrics is a relative contraindication if it is, and it can actually be modified for and managed alongside an MDT with a performance-informed obstetrician and a obstetric-informed sports physician, essentially. And not finally, but we'll now look at sort of why modifications aren't enough. I think you'll probably be able to see from sort of what I've talked about the modifications, the challenges through each trimester, and then the obstetric complications. You'll probably be able to see that modifications alone aren't actually enough. And what we really need is individualized care strategies for each athlete, because no two athletes are identical and no two pregnancies, even in the same athlete, are identical. So the modifications, they do need to happen, but they kind of need to happen in real time. As a symptom is presenting itself, as a complication is arising or not arising, etc., we need to be able to, this is why it's so difficult when people ask me, can you write a framework or can you just write a guideline or etc. that can be applied? And you can't really apply cookie cutter sort of programs to pregnant women and athletes in this sense because of all of these changes that there's so much variation. Essentially, we have to be proactive because, as I said, we know certain physiological and biomechanical things happen in each trimester, but essentially, we can't expect that every athlete is going to have all of them or have none of them, etc. So we have to be prepared to be reactive as well. So as a symptom arises, as a problem arises, that is the point at which we would make a modification or further modify if needed. So essentially, I always recommend week by week check-ins with your athletes because the hormones are changing, the biomechanics are changing, and in that regard, the symptoms would also be changing. Now, something else that I talk about is something called the athlete brain. So what is it and what are the risks from it? So the athlete brain is essentially a mindset that a lot of successful athletes will have, which is they think that they are the exception because generally in their careers and in sports, they actually are, so they think that in pregnancy, it's fine, I'll be able to do this, I'll be able to do this. When actually the voice that makes them successful as an athlete, that tells them to push through little niggling pains, etc., or to carry on when they don't want to, those voices are not actually beneficial in pregnancy. So the very voices and the very mindset that has made them a successful athlete is not the mindset that is going to get them through pregnancy safely and successfully to return postpartum. And as a performance team, again, touching on the mental health side of things, we need to be aware of this, that your athletes will sometimes want to do more, want to do things when actually it may not necessarily from a longevity perspective be in their best interest. But again, being able to appreciate where they're coming from, that for them, it's identity, it's their body, that suddenly doesn't feel like theirs, etc. So there's a lot of mental health aspects, which if you have mental health performance coaches on your teams, that is, they're the best people to then get involved as well. So again, the summary would be that we need to build athlete-specific, individualized frameworks that take the sports and the symptoms of that athlete into account. And now we get to postpartum. So I think you had some questions, but I can go through and we can answer them as they become relevant, maybe. So yes, go on.
So this question has come in a little bit earlier and they've been patiently waiting, so I'll go through it. So this is from someone who says, actually for a postpartum athlete who's stopped breastfeeding and maybe they're 1 to 2 years post-birth, I've come across discussions which suggest, this is from the question asker, suggest UK compared to other nations don't support the postpartum nutrient deficits as well. Do you think postpartum athletes post-breastfeeding, or when they're back to activity and training, need better supplementation to restore body stores more than the basic off-the-shelf Pregnacare? And if so, what would you recommend?
Really, really good point. So one thing that the person has mentioned or hinted on is something that I always talk about is postpartum, 1 to 2 years. Postpartum is forever. So a lot of times people will say, oh, I'm 18 months since I had a baby now, I should be okay. Well, no, postpartum, your body has changed forever. It will never go back to the pre-pregnancy way it was. However, it doesn't mean it needs to be worse. It could potentially be better if we support but essentially postpartum as a time frame in the life cycle of a female athlete is forever. So that's a good point that question's actually brought out. Going back to breastfeeding. So the question was about nutritional support. I find that the athletes I have spoken to, essentially like they ended up, for example, going into Red S, etc., because there wasn't any awareness or there wasn't the availability or accessibility to a nutritionist or a dietitian to help them understand that actually, even a woman who's not an athlete, your calorie requirement, and this is again, is going to vary so much individual to individual, your calorie requirement goes up by about 500 calories if you're not necessarily training, performing, etc., just by breastfeeding. So you need to take that into account. And then on top of that, if you're then training, have performance goals, etc. So the answer is yes. The needs, sort of nutritional support needs are there. The sort of micronutrient support needs are there as well. In terms of what's off the shelf, see, I think it's much more useful if you've got the accessibility to someone who can check your bloods, check your mineral status, check certain things, and then you can supplement accordingly. But generally, calcium, vitamin D, iron are the things that are just very basic. And actually, I know I'm saying they're basic, but you'd be surprised at how many athletes postnatally are not told that they need to be on these if they're breastfeeding or even not breastfeeding, but just because their stores will be depleted after pregnancy. So to continue.
Great, thanks for that insight.
So back to the sort of pathway. Again, as I've said, frameworks and pathways, they're not very linear in pregnancy and postpartum, but for argument's sake, this is a sort of one way that I like to sort of talk about postpartum return is essentially the 4 R's. So you've got your recovery, your rehab, your rebuild, and then your return. And essentially, these are still, to an extent, squashed up. In an ideal world, if you were to look at pregnancy and postpartum physiology, it takes about 18 months before you can say that somebody has returned to their pre-pregnancy state from a physiological perspective. But when we look at things from returns to sport sort of perspective, we have to look at sort of the hand that we are dealt, essentially, in terms of performance timelines, seasons, sort of Olympic cycles, etc. So even with a squashed up timeline, essentially you shouldn't really be, in an ideal world, looking at returning goals, sort of personal best goals or records, etc., or competing till at least 9 months plus. But we know in practice, and we know from athlete mothers, that this is not always the case, whether it's something that they want or whether it's something that they have to conform to for other reasons. So essentially, we work with athletes with whatever it is that they are up against in terms of their return timelines. But essentially, the first 6 weeks, you're recovering from your delivery. So whether that's vaginal delivery, whether that's a cesarean section, whether that's an instrumental delivery, that includes recovering from wound healing. And to add insult to injury, these things would be hard enough to recover from in terms of open abdominal surgery, or vaginal delivery or wound healing with adequate nutrition, adequate hydration, adequate sleep, but actually you've got a small baby to be keeping alive. So actually sleep deprivation comes into it, not necessarily paying attention to your nutrition as much as you would want to. And then again, breastfeeding and mental health play a huge role in this first 6 weeks in establishing. And a lot of the time, I find that postpartum depression in my patients, just generally in both private and my NHS work, breastfeeding struggles are probably one of the number one reasons for or contributing to postpartum depression. And I think it's again, something not talked about. We just assume, unless we know someone who's struggled with breastfeeding, that you have a baby and your body just knows what it needs to do and you just crack on and breastfeed. But actually, the reality is quite different. And the first 6 weeks is literally recovering from all of these things, including physical as well as the mental health side. So then, but that doesn't mean that you're doing absolutely nothing in that time. And it just means to sort of from the athlete perspective to essentially be a bit less harsh on yourself if you're not able to get back to sort of doing your core rehab and these sort of things. But if you are able to and you want to and you actually feel that you need an element of a break from the baby side of things and actually want to do something, we would recommend that you can start your pelvic floor and core rehab from as soon as postnatally as you physically feel that you are able to. And these things won't be very strenuous. They will literally be, again, breath work. It would be essentially what you are needing to do post-delivery is reconnect your brain to your core, to your pelvic floor, because these connections get essentially disturbed through pregnancy, through the biomechanical and the hormonal changes. So that then brings us on to the next 6 weeks to 6 months, the rehab phase. At this point, you're looking at essentially, I guess why I've named them the way I have is more from an athlete and a performance team's perspective. It gets your mind around what you're essentially building your expectations. If you know that you're in the rehab phase, you're not going to start thinking, well, I'm not lifting, or I'm not as fast as, I'm not running, I'm not doing X, Y, Z the way I was essentially 6 months pre-pregnancy, etc. It just sets your expectations. So 6 months, up to 6 months, you're still in the rehab phase. So you're looking at rehabbing your core and your pelvic floor. You're working with a pelvic floor physiotherapist to address any new symptoms, address any old symptoms that may be presenting differently, rebuilding the connections, and basically rehabbing the movement patterns and things that you know are going to be important for your return to your sport, and seeing how you can work on the foundations that will get you to that place. So again, this time is actually really important because as athletes, everybody has certain ways of moving or doing certain things that are sport specific, but it's quite easy to have picked up bad habits in movement strategies and the way you do certain things. And actually, postnatally is one great time because you're essentially having to start from the bottom, build your foundations back up. And it's a great time to readdress sort of any of those sort of bad habits that you might have picked up in terms of movement patterns, etc., or breath strategies, etc. So again, important person to have on board on your team is a pelvic floor physiotherapist. And then you get to the 6 to 9 months. And again, at that point, your mindset should be on the rebuilding. At this point, you're rebuilding all of the blocks it is that you need for your sport. So whether it's, again, in case of sort of Olympic lifting, etc., or powerlifting, you're rebuilding your strength back to trying to get back to what you were doing pre-pregnancy. And it's only at 9 months plus that you should be looking at actually returning to competing, making any new goals, breaking any records, etc. So in the 6 to 9 month phase, you're looking at rebuilding your strength and dynamic movement patterns, rebuilding around any new symptoms that you have. And it's very common for athletes to find, or for women to find, that actually pregnancy has made them fitter in certain things. Their heart rate variability may have improved, their resting heart rate may have improved. Even if they had certain symptoms that stopped them doing certain things, the pregnancy hormones are actually pro-anabolic to an extent, like the growth hormones, etc. So you may find that you've inadvertently actually gained strength in certain areas if you've continued training. So it's not all downhill and then you're having to build back up. You may actually notice things that are a bit different, but in a good way. But yes, it's at this 6 to 9 month phase that you can then start pushing some boundaries of strength, speed, etc., and testing them. But again, like I said, this timeline is kind of a shortened ideal. In an ideal world, if you speak to athletes, none of the ones that I speak to have ever regretted taking their time in returning, but few have regretted rushing their return. And that is something that you will find. But again, some of the aspects of their return decisions are not necessarily in their hands, and this is why it's important to be having these conversations with the governing bodies, with the clubs, the teams, so that realistic expectations can be put on our athletes. So then again, key considerations for return to sport. We've talked about nutrition, and it's an important aspect, which I feel is often neglected. So you've got an increased basal metabolic rate postnatally as well. But on top of that, you've got a lack of sleep. So your cortisol levels are increased. You're producing breast milk. So you're depleting yourself of certain minerals, vitamins, and certain hormones. And the breastfeeding does actually keep you in a certain hormonal state, more similar to pregnancy than it does postnatally. So for as long as you are breastfeeding, you're not necessarily hormonally going to get back to your pre-pregnancy hormonal status. But that's not necessarily all bad, essentially, but it's just something to be aware of. And an important one is the risk of red S. So again, something that we need to be screening and monitoring more for prevention. So we should be having access to dietitians and nutritionists for athletes who are breastfeeding or not, but essentially postnatal. Simple things like iron supplementation is often forgotten and is and can contribute to anemia, which will affect performance. So these are really simple things that we can optimize in our athletes. With breastfeeding, there's a high risk. We've already talked about the risk of postpartum depression as a result of breastfeeding struggles. So we need to make sure that the nutritional needs that we're actually addressing their nutritional needs due to breastfeeding. But an important other aspect of breastfeeding and pumping is that is quite relevant to getting athletes to be encouraged to return is actually making spaces that are breastfeeding and pumping friendly. The number of times I've spoken to athletes who have gone through sort of postpartum return, the things that they struggled most with was mostly with childcare provisions, postnatally, areas that were breastfeeding and pumping friendly. So these are the things that as teams that are supporting athletes, we need to be thinking not just about the physiology, the athlete, etc., but everything that needs the logistics and the structure that needs to be available around. If we're saying that we are supporting athletes into motherhood and beyond, then we really need to be looking at it from a logistical perspective as well. From a pelvic health perspective, urinary incontinence, pressure, pain, do they need a pelvic floor physiotherapist? I generally say that postpartum, everybody needs to have a pelvic floor physiotherapist, not just if you have symptoms, because there may be considerations that you need to have put into place to prevent you getting any symptoms as well. So in terms of SPD and PGP recovery, one thing that we know from what we learn in the textbooks is you deliver 6 weeks later, your hormones go back to normal, your SPD goes away. That's not always true. It, in practice, does take a lot longer. When I speak to athletes and in my own personal experience, definitely takes a lot longer than the first 6 weeks to get your SPD symptoms to resolve. But again, having a good specific pelvic floor physiotherapist who knows how to manage SPD and PGP, because it may be that certain parts of your core are not firing and therefore your pelvis is still giving symptoms. And the last part, or the second to last part, is childcare provisions. We kind of mentioned this around breastfeeding as well. These athletes are mums. They're not just athletes. They have babies that they need to be keeping alive. And if we look at them purely as an athlete and forget that they have a baby and that they're a mum, that's not going to encourage them to return, because we're not putting the logistics in place for them to be able to return. So again, we need childcare provisions to be in the maternity policies and the maternity guidelines, and to make practice grounds, clubs, etc., sort of inclusive towards that. And mental health. I keep talking about mental health because it's an important one. There's been huge changes in identity, in sleep, body image. These things affect regular women, but for athletes who are in the public eye, or they're looking at their performance, they're probably likely to be more critical of these things. And we need to be aware of these and to be able to support them. And one thing that I mentioned that I was going to talk about was myth busting. So there are a lot of myths around training in pregnancy and postpartum, and we'll kind of you'll now see why some of these don't make any sense. So a lot of well-intentioned people will say things like, it's fine, just do what you've always done. But actually, if you now know what we know from going through the presentation of the physiological changes, the biomechanical changes, you'll see why that isn't really good advice, because actually there's no context there. There's no care of the physiology or the biomechanics. So actually doing what you've always done doesn't necessarily help. The other one is listen to your body. Well, what are we listening for? The athletes, if the athlete has the mindset sort of around athlete brain, then actually what voice are we telling them to listen to? It's not the voice that's going to help them through training through pregnancy and their postpartum return and longevity. Sometimes a lot of people will say, well, oh, pregnancy training and postpartum is fine. It's just all about modifying. It's just about modifying. But we can see now that it's not just about modifying. And even in modifying, it's very nuanced, it's very individualized, and it requires a lot of people to be working with the athlete together. Another myth is prevention of diastasis, which I've already touched on. 100% of pregnant women will have the separation of the rectus abdominis muscles, because that is a physiological adaptation to pregnancy. But the other myth is that all diastasis or all subsequent sort of diastasis that remains equals cord dysfunction. And that's also not true, because actually you may have a separation months later, 9, 10, 12, 18 months later, you may still have separation of the rectus abdominis muscles. But actually, if you've built up your core and the linea alba is actually strong enough and your core's able to function, it doesn't really matter if you still have a separation. Now, cosmetically and aesthetically, that's a different consideration. And yes, if that's the case, then there's surgical options for that. And if there is dysfunction, then there's also surgical options for that as well. The other myth that we hear around, mainly around sort of fitness influencer circles, is that you can train for birth, that if you're fit and healthy, that you're not going to get certain complications, or that you essentially are not going to have an obstetric emergency in labor and delivery. And that's just simply not true. If it was true, I'm on call 24/7 when I'm on call. And that's very much for the reasons that in obstetrics, things can change in a second, and essentially how fit you are, how healthy you are, what your pregnancy, your antenatal journey has looked like, does not in any way, to an extent, prevent you from having an emergency in labor. So you cannot train for birth. Essentially, making good choices, being active, does reduce your risk of getting sort of gestational diabetes, for example, certain complications like gestational hypertension, protecting your mental health, etc. But what we actually find is that a lot of athletes and a lot of active women will actually have a tight pelvic floor. So if anything, empirically, we don't have the research data yet to confirm this, but what we find empirically is that a lot of athletes actually will struggle to have sort of in the second stage of labor to actually have a vaginal delivery without assistance sometimes, because their pelvic floor is actually too tight. And which is why it's really, really important to have included down training of the pelvic floor in their training from essentially the first trimester onwards. And the last myth is, because XYZ, other athlete, other person did it, so can I. And we now know, you'll know, that actually no two athletes are the same and no two pregnancies are the same. So that is a complete myth. And then finally, we've kind of touched on this, which is the dream team. So if you had all the resources in the world and all the people that you would need, what does your ideal MDT look like? So the pelvic floor physiotherapist, essentially from the start of your pregnancy through to the return back to competing level, that would be an ideal. But at the very least, for the first 6 months postnatally and throughout pregnancy. The next person would be sort of a women health aware or obstetric aware informed sports medicine physician. So someone who has experience managing sort of pregnant athletes. And then alongside that, having a performance-informed obstetrician or gynecologist, having a dietitian or nutritionist accessible, and a strength and conditioning coach that's familiar with coaching pregnant athletes. Because as you'll see from when we've gone through the different trimesters, etc. If you understand the mechanics and the physiology of pregnancy, it's quite easy for you to then say, well, okay, if you can't do X, Y, Z which is sport specific, what movement patterns and things can you do that will still mean that you are progressing throughout your pregnancy in terms of your training, and which will help your postpartum return. And then an ideal, but I think probably still integral, is a sports or performance mental health specialist. And if you have them already incorporated into your team, into your performance teams, then they're great to have on board for the various mental health challenges that pregnancy and motherhood brings. Any other questions? Let's see if I can.
Great, thank you for those insights, both clinical, professional and personal. It's been a really fantastic journey to listen into your talk today, Dr. Zafrani. We thank you for the time you've committed to us today. And if people do want to find you online, we will share your contact details. I want to say a massive thanks for supporting us and being with us here on the MSK Playbook series webinar. I will pause for a second if in case there's any last questions. We were really excited. I'll say thanks to the team at Radiology Seminars for setting up the webinar. We've had registrants from North America, Europe, Asia, Africa, Australasia. The only place we haven't had is South America. So if you know anyone from South America who'd like to sign up to the MSK Playbook webinar next time, tell them to sign up. We'd love to have someone from South America. Whilst we're just waiting for any last questions, Dr. Zafrani has kindly made the lecture slides available, and the lecture slides will be made available online. And I'll just share my screen so we can just show people how to get access to that. So if this is whet your appetite and you want to learn more, if you head across to the MSK Playbook website and sign up to free stuff, if you click on the free stuff tab here at the top, you'll get access to Dr. Zafrani's lecture slides, including the references. Thanks a lot to Imran as well at the beginning of the talk, who opened up with some information about imaging. And it was so easy to look at a scan and say, look, I've seen something on an ultrasound. It looks like a lipoma. I'm going to stop there. And we know there's lots of anxiety around medical imaging, particularly in MSK medicine. And when is it a red flag? When is there something else going on? So whilst we're waiting for any last questions, I'll just share this. The team at Radiology Seminars have been really, really active and have started a new MSK ultrasound masterclass. You can do upper limb and lower limb masterclass in one day and learn the tips and tricks of how to ultrasound in clinic. Imran is great on the MSK Playbook masterclass and give us some really cool insights and tips and tricks. We also now have an MSK ultrasound mentorship package. So if you do the 2 masterclass packages and you said, you know what, I want to take it further, you can do 8 days of training to build up your competencies to develop ultrasound skills, to get good at picking up common sports injuries, integrate into your point of care ultrasound in clinic, and learn hopefully how to apply imaging in clinic and also in your sports medicine practice. So if you do want to learn more about MRI imaging, you can go from the image on the left, where this doesn't look like a normal ATFL, to the right, where you can look at the ultrasound and get good at that in clinic. So please do keep your comments coming in and do share with us your experiences. And if there are any more questions for Dr. Zafrani, we'll be available on the webinar for a couple more minutes. Dr. Zafrani, we've had a lot of questions from people who work within a sports team. They're looking after a female team, and they would like to know, as part of a pre-season medical, we always have a few takeaways. What sort of questions or clinical family history, what sort of things might they like to integrate in their sort of screening, pre-screening medicals, or maybe mid-season? What sort of things would be really important to know about in terms of obstetric history and fertility history?
I think it depends. I mean, it's a difficult one, isn't it? Because if you start asking fertility related questions and it's not something, and they're very young and they've not even thought about it, it feels a bit intrusive. But I appreciate that, yes, if we're talking about these things, it's not a bad idea to get them thinking about it, or at least making them feel comfortable enough that they can then come to their teams. But I guess because menstrual disorders, and that includes pain like endometriosis, adenomyosis, etc., because these things actually do affect performance, I think it's well within performance teams' interest to be asking about them. So I think pelvic floor symptoms, urinary leakage, incontinence, pressure, and menstrual dysfunction. So are they, how are their experience of their periods? Is it affecting their performance? How many days off, or do they feel that their performance is affected by their periods, etc.? Because these things happen monthly, and if it's, if you're finding that you're not performing as well as you'd like to every month, it's going to affect, and it's in the interest of the team. So menstrual disorders, pelvic floor symptoms. And then, yes, you'll probably find from menstrual disorders, if they've got things, signs and symptoms suggestive of endometriosis, you can send them along to the gynecologist. But that will also get them thinking, and will sort of pre-screen them for fertility things as well.
Great, fantastic. We'll wait for any last questions, and it's great that you've raised so many interesting points. You've talked about pregnancy guidelines, you talked about the importance of identifying red S and those key questions to ask about, and you've given some really useful and insightful information about obstetric red flags, things to be aware of, particularly as we approach delivery. We always ask our guests for maybe 3 take-homes or key messages. Is there anything that you would give us as your key take-homes from today's talk?
I think in terms of the take-homes, firstly, it needs to be, everything that we do with the pregnant athlete needs to be individualized. It is nuanced. So with that in mind, it needs to be on a one-to-one basis with each athlete. Another take-home would be, don't forget mental health. Whether that's from preconception all the way through to postnatal. That's an important part to not forget. And the third one would be, baby brain. I can't remember. Oh, yes, one that keeps coming up. So a lot of sports and governing bodies now have sort of maternity policies. But what I actually find when I speak to the athletes is it's all good and well having a policy, but actually you need people on the ground that are able to implement the policy. And what in practice, when I speak to athletes, is they'll have a policy, but their experience is very different to what the policy has said. And that's because there is a gap of not having the right people that are able to implement what's in the policy into practice. And we'll find that in different specialties in medicine, that you can have a guideline that's sitting on a shelf, but until you have the clinicians or the clinical people or the performance teams in this case able to actually implement the findings or the recommendations of the guideline into practice, it just sits in a shelf. So the last take home would be, look at your policies, but also look at finding ways and getting the right people on board to help you implement those guidelines into practice.
Great. Thank you for that talk and those take homes. If you want to put your contact details on the screen as the last slide, then that will give us, our audience, a great way to interact with you, find you, hopefully share their thoughts. And if you enjoyed the show today, if you enjoyed the webinar, please give us a like, share, or retweet any of our content. It gives us a really nice signal to say, yeah, keep doing more of this. And I'm sure we'll see Dr. Zafrani on a future webinar. Thank you so much. Thanks for joining us today. Okay, thank you so much.
Yeah.
Thank you for your time.
Thank you very much. Take care.